Hello, my name is Daniel Ale, and I'm from the University of Texas at Austin Dell Medical School, currently a PGY2. Our case presentation starts with an 18-year-old man with recent COVID-19 infection who presented to the emergency department with fever and night sweats in the setting of subacute polyarthralgia, fatigue, and rash for 6 weeks duration. Upon further questioning, he was a previously healthy individual with no past medical history prior to having the COVID-19 infection. His physical exam revealed a diffuse hyperpigmented rash involving his thighs, chest, and back, seen in Figure 1, and he also had mild splenomegaly, seen in Figure 2. Labs showed significantly elevated inflammatory markers with an ESR of 142, a CRP of 16, and a ferritin level of 40,000. He had elevated IL-2 level of 1700 and a severe anemia with a hemoglobin of 6.1. In the setting of these extreme lab values, it was an easy decision to admit the patient for further workup. Given the timeline of events, the patient's symptoms seem to be most consistent with a type of post-COVID syndrome. The differential, however, for pro-inflammatory conditions following a COVID-19 infection is generally broad, which poses a diagnostic challenge. Consideration for rare conditions such as secondary hemophagocytic lymphohistiocytosis, otherwise known as SHLH, and its subsets must be made to avoid life-threatening complications that may occur if left untreated. And while it is imperative to identify the trigger of the inflammatory state, it is equally important to rule out alternative etiologies, including infections, malignancy, or other autoimmune diseases. Our workup included ruling out infectious etiologies with viral, fungal, and bacterial serologies, in addition to blood and sputum cultures, which were all negative. A peripheral smear revealed a normocytic normochromic anemia, but was otherwise unremarkable. A skin biopsy was consistent with Still's disease. A bone marrow biopsy demonstrated hemophagocytosis, represented by Figure 4, and a lymph node biopsy was negative for any signs of malignancy. An SPEP revealed monoclonal gammopathy of unknown significance. CT angiography did not show any signs of vasculitis, and a transthoracic echocardiogram was only significant for a small pericardial effusion, as seen in Figure 3. Once infectious and malignant processes were ruled out, he began treatment with IV methylprednisolone for suspected SHLH and adult onset Still's disease. This led to both clinical and laboratory improvement. At outpatient follow-up, it was determined that the patient's symptoms were well controlled while on a prednisone taper post-discharge. His follow-up labs showed a normal CMP, a normal hemoglobin, and mostly downtrending inflammatory markers with the exception of a CRP that was still elevated at 36. This case presentation highlights the extensive workup needed to prevent anchoring bias. Patients with pro-inflammatory states often present with nonspecific symptoms, and differential diagnoses can be both broad and overlapping. Figure 5 shows our approach to grouping potential sources of inflammation. Initially, it was suspected that the patient had a pro-inflammatory state derived solely from a COVID-19 infection. However, further workup revealed an underlying syndrome of SHLH coinciding with adult onset Still's disease. Although his diagnostic differential was divergent, the recommended treatment option is convergent, utilizing high-dose glucocorticoids for both conditions. Ultimately, it was critical to delay the onset of therapy until infectious and malignant etiologies were ruled out, despite the risk for developing additional complications from the autoimmune condition. Thus, with this presentation, we emphasize the importance of utilizing clear algorithms as a systematic approach to reach a final diagnosis, no matter the complexity.